dobry, nazywam się Jacek Mikosiński. Jestem chirurgiem ogólnym i naczyniowym z wieloletnią praktyką. Z uwagi na możliwości działania mojej kliniki Mikomet zostałem zaproszony przez pana profesora Hansa Smolę do badania klinicznego pod tytułem Ocena kliniczna opatrunku piankowego zawierającego uwodniony poliuretan stymulujący działanie czynników wzrostu. Efektem tej pracy było naukowe opracowanie w Journal of Care we wrześniu 2018. Szanowni Państwo, jest mi bardzo miło jako współautor, że mogę Państwa zaprosić na wykład pana profesora Hansa Smolę.
Hello and welcome to this presentation on hydrated polyurethanes and the effect on wound healing. As this is an online event, let me please introduce myself. My name is Hans Smola and I'm the Medical Director of the Paul Hartmann AG in Germany. I also teach dermatology at the University of Cologne. Please let me start with the granulation epithelialization phase, and that is after the cleansing phase has taken place and endogenous debridement successfully reduced excessive protease levels to levels that permit wound healing to happen. In the second phase, where you observe stimulation of the granulation tissue by growth factors and where you observe epithelialization, that is the phase I would like to talk in this presentation. And this is shown here in much more detail. A lot of research has gone into the underlying mechanisms identifying the growth factor networks that stimulate the wound healing process. You have autocrine factors that keratinocytes produce themselves and which stimulate the leading edge keratinocytes to migrate into the wound bed. But you also have growth factors that are coming from the dermis, from fibroblasts, which stimulate keratinocytes to divide and migrate. And you have macrophages and vessels, and all these cells contribute to producing growth factors that are beneficial for the proliferation and migration of the keratinocytes, and of course the production of extracellular matrix. On the left-hand side you see a wound that is perfectly healing, with epithelialization from islands within the granulation tissue. And you could speculate that in this wound application of endogenous growth factors might even boost the wound healing. Unfortunately, clinical trials with exogenous growth factors have not been too successful, and apart from PDGF, none have entered the clinics. On the right-hand side, you see a different concept that requires the presence of endogenous growth factors. Here the mechanism is to increase growth factor activity. And this could be done by drawing out water so that the concentration of the growth factors increases in a smaller volume, and this can drive now keratinocyte migration and division. Growth factors, the pinkish large circles on the left, cannot enter the hydrated polyurethanes. They become more concentrated in a smaller volume, and they can more easily elicit a biological response. So simply taking out the water selectively by these hydrated polyurethane, it is possible to increase the relative concentration of growth factors, and this should have an effect. And that this works is shown here. If you take one growth factor called HGF, that stands for hepatocyte growth factor, that is responsible for keratinocytes to divide, but most importantly that these cells migrate. If you have a complex biological fluid, in this case here it was tissue culture medium, and if you incubate this fluid with hydrated polyurethanes, you could see that after 4 hours incubation, the growth factor concentration starts to increase as shown in the light blue bars, and after 24 hours this reaches almost a 3-fold concentration of this growth factor. It is just by selective absorption of water. To show the biological effect, we did scratch assays or in vitro wound healing assays. On confluent keratinocyte monolayers, you wound the cells with a pipette tip You scratch the culture dish, and on the left-hand side, at the start, you see the defect in the middle of the picture. After 6 hours, you see that the cells are starting to migrate and fill the defect, and it is pure migration, not yet cell proliferation. Now, if you add hepatocyte growth factors to these cultures, in our instances 25 nanograms per milliliter, you see that this defect in the center becomes much smaller simply because the cells get the information from hepatocyte growth factor to migrate faster and close this defect. Now, if you take the same concentration of HGF, but pre-absorb it with hydrated polyurethanes, the defect in the middle is reduced to very low levels. This is one way how you can boost growth factors, not by de novo synthesis, but actually by increasing their relative activity, in our case, through the removal of water. Encouraged by these in vitro results, we initiated the Boost Closure study. This was a study on patients with venous leg ulcers. The patients were followed for 8 weeks of treatment with a foam dressing containing hydrated polyurethanes. We measured the development of the wound area reduction rate, and the usability parameters and quality of life. The study was performed in Germany and Poland and published 2018 in the Journal of Wound Care. I'd like to show the patient characteristics of the study population. 123 patients were recruited. Female and male percentages were 41% and 58% respectively. Age, body weight, height, body mass index were fairly standard for patients in those types of studies. The history of deep vein thrombosis in the affected limb was 22%, and the history of venous surgery was 24%. The wound baseline characteristics of our study population were a history of 11.5 months on average, and the total number of wounds that were present for more than 6 months was 56.1%. Important for the prediction of whether these wounds heal easily or not, the wound size and the number of wounds larger than 10 square centimeters is important. 42.3% of patients showed wounds that are difficult to heal with a size of more than 10 square centimeters. Now let me jump to the results. On the left diagram, you see the development of the absolute wound area in the light blue bars. The average size decreased from 13.3 square centimeters to 10.5 square centimeters at the end. The dark blue dots show median responses. So the median decreased from 8.6 square centimeters to 4.4 at week 8. This corresponds to an absolute wound size reduction on average of 2.8 square centimeters at week 8, and for the median value of 4.4 square centimeters. The third diagram from the left shows relative wound area reduction at week 8. There was a reduction by 25.2% on average, and the median reduction was 48.8%. Wound edge progression, according to the Gilman calculation, was 3.6 millimeters at 8 weeks. When we look at the number of wounds, or the percentage of patients who reach a relative wound area reduction by 40% or more after 8 weeks, we saw that 54.5% of the study population reached this target. And if we apply a stricter parameter of at least 60% or more wound area reduction, 44.5% of the study population reached this level. This is a very busy slide, but it's very informative. If you investigate whether wounds with a good granulation tissue at this start behave different from wounds that do not have much granulation tissue, you can divide our study population in 2 groups. And this is shown by the red horizontal line at 45% of granulation tissue at the beginning. you can see that those with more than 45% granulation tissue at the beginning are preferentially in the left-hand corner of this diagram, and that indicates healing. If you look at the lower half, so below 45% granulation tissue at the beginning, you see that more wounds had a poor response with an increasing size even. And this is common in most venous leg ulcer healing studies. There is a proportion of patients that does not respond. So this therapy depends on the presence of granulation tissue and hence the presence of endogenous growth factors, as the theory suggests. As a clinician, I think most of you are very much interested how do these results compare to other studies in similar populations. We had a look and identified one study that was published by Sylvie Mohm in 2012. This study was a randomized controlled trial on venous leg ulcer patients and compared a wound dressing containing an active pharmaceutical ingredient with a standard foam dressing. If you look at the wound parameters in both studies, we had to re-evaluate our wounds, so that our wounds had at least 45% of granulation tissue at the start. So we had 100 wounds to work with and compare with the historical data of the Mohm study. The only difference we observed was the duration of the wounds before study inclusion. Our group had a slightly shorter history. For the other reported parameters like fibrin deposits, granulation tissue, and wound size, the difference were not significant. Now, if you compare our results with the historical controls, you see that the hydrated polyurethane dressings showed a very similar response rate to the dressing with the active pharmaceutical ingredient, which is the bar in the middle. Both groups showed a significant difference between the standard foam and the parameters. The principle of hydrated polyurethanes achieved a similar response like the active pharmaceutical ingredient containing dressing, and it seems that the principle works very well. Now let me summarize. Hydrated polyurethanes can stimulate growth factor activities. The hydrated polyurethane containing wound dressing, HydroTac in this case, showed a significantly better wound area reduction compared with historical data for standard foam dressings. They were very good acceptance in handling data. Unfortunately, I didn't have time to get into this at this presentation. So thank you very much for your attention, and as this is an online event, please send me your questions and comments to either my university email address or at hans.smola@hartmann.info, and I thank you very much for your attention.